Like it's time. Well, good morning and welcome to Grand Rounds. For those that aren't joining us in the Tanglewood Mill Mountain Room but are roaming around Tanglewood, come join us. We've got a great guest speaker that I got the pleasure to introduce this morning. Dr. Eman Mahdi earned her medical degree at the University of Baghdad College of Medicine and went on to complete her internship there in Baghdad at the Iraqi Ministry of Health. She then successfully went to Jordan and completed diagnostic radiology and then moved to the Washington area and did a fellowship in neuroradiology at Georgetown and then shifted to pediatric imaging where she started studying and doing a research fellowship in fetal and neonatal brain imaging and fellowships in pediatric radiology and pediatric neuroradiology at Children's National. She's board certified in diagnostic with subspecialty diagnostic radiology with subspecialty board certification in neuroradiology and pediatric radiology. She joined the Children's Hospital of Richmond as an clinical assistant professor in radiology and neuroradiology for pediatrics in January of 2022 after working as a pediatric and neuroradiologist at the University of Missouri in Columbia. She currently serves as the VCU Pediatric Radiology Section Education Director, Medical Student Clerkship Director, and co-chair of the Radiology Curriculum Committee. She's a member of many national, international organizations, and she's going to talk to us this morning about hypoxic ischemic brain injury. And I'm going to stop there because I think that she's so well accomplished. I want to hear what she has, what we're going to learn today. Thank you.
Thank you so much for the introduction. It's my great pleasure to be with you today. So yes, the topic will be about hypoxic ischemic brain injury, a multimodality approach. I have no financial disclosure. As you know, brain hypoxic ischemic injury is a devastating disease that can lead to death or profound neurological disability. Treatment is usually supportive, including hypothermia or administration of excitatory amino acid antagonists, with a narrow time window of about 6 hours. Neuroimaging that we can provide is ultrasound, CT, or MRI. The objectives for my talk today is to review the pathophysiology, review the specific imaging findings in neonates, including term and preterm, and then older kids, including the infant and older children. And then to describe the role of advanced MR imaging technique in evaluation for hypoxic ischemic injury, including MR spectroscopy, ADC values, and ASL perfusion, and lastly, discuss imaging choices. These are the outline for my talk today. We'll start with pathophysiology. So there are two underlying pathophysiological processes that contribute to the injury, which is either the decreased cerebral blood flow, the ischemia, or reduction in blood oxygenation, the hypoxemia. Infants and children are more likely to suffer from asphyxiating event that will result in hypoxemia and brain hypoxia. As the process continues, this will result in cardiac hypoxia and eventually decrease in cardiac output and brain ischemia. So brain injury resulting from asphyxia is usually the consequence of ischemia superimposed on hypoxia. And that's different from adult, where it's mostly the process will start with ischemia secondary to stroke, clot, or something. As we move with the pathophysiological processes, so when brain ischemia happens, this will shift the brain from oxidative phosphorylation to the use of anaerobic metabolism, with resultant in cellular changes as decrease in ATP, increased lactate and free radicals, with changes within the cellular membrane and depolarization resulting in release of the excitatory neurotransmitters such as the glutamate. As we continue with the process, it's important to highlight the point of selective vulnerability. So global hypoxic ischemic insults do not affect the brain structures uniformly. There are certain tissue within the brain are more likely to be injured or even injured earlier than the others. So example of this are the areas with high concentration of glutamate, usually within the gray matter, or the higher energy demand within the central gray matter structures are more likely to be injured. And other point that I wanted to highlight is the concept of delayed cell death from apoptosis, which can take up to days following the initial insult and contribute to what we find later. And then this take me to just highlight the secondary energy failure. So as you see in this timetable, that's the baseline, and then hypoxic ischemic event happen, resuscitation, and then we're almost back to baseline. However, there is still, that's what I call the latent phase. There is still some structural damage happening during this phase, which can take up to 24 hours. And as a result of this structural damage, there will be depletion of metabolite and cellular changes, resulting in secondary energy failure. So brain damage continued despite the initial apparent improvement during the latent phase. So that conclude them briefly about the pathophysiology. We'll start with talking about the injury in neonate. Before I start, I just want to highlight the difference between the use of terminology between preterm and term, which it's more controversial. However, in terms of injury, most authors describe a distinct pattern of brain injury in neonates who are less than 36 weeks of gestation, to be different from the pattern of injury in those older or equal to 36 weeks of gestation. On Barkovich et al., they said premature birth is the birth before 37 weeks, very preterm is between the 28 to 31 weeks, and then extremely preterm is less than 28 weeks. And so hypoxic ischemic injury is more as like the brain injury that caused by the insufficient oxygenation or blood flow, but that's different from the terminology for hypoxic ischemic encephalopathy, which is more as a clinical diagnosis based on poor Apgar score, seizure, coma, hypotonia, multi-organ dysfunction, and metabolic acidosis. So what we really talk about in terms of imaging, it's more as like the injury, the hypoxic ischemic injury, and the encephalopathy is more as the clinical diagnosis. Imaging approach. So we have the ultrasound, CT, and MRI, and I'll just highlight them pros and cons for each of these. So ultrasound is convenient, non-invasive, low cost, and it's available at bedside, no radiation exposure. It's sensitive for hemorrhage, for periventricular leukomalacia, hydrocephalus, and also we can get some Doppler interrogation that will give us the resistive indices, so we get an idea about the intracranial pressure. However, it's more operator dependent and has less sensitivity for the periphery of the brain. Compared to CT, it's a rapid that can be happening to assess for hemorrhage in a sick neonate without the need for sedation, which is an issue for MRI. However, it has radiation dose, and it's less sensitive during the neonatal period in terms of resolution, like the contrast resolution for the brain. Compared to MRI, it's the most sensitive and the specific modality, especially when we think about the diffusion weighted, the MR spectroscopy, more than the just standard T1 and T2 MRI sequences. However, the disadvantage from MRI is off-hour MRI is not always available, and then the need for sedation, transport issue, and then limited access to MRI in smaller facilities. So factors affecting the pattern of injury, including the brain maturation at the time of insult, the severity of hypotension, and then the duration of the event. So as you see here within the picture, that's between preterm and term, in like a mild to moderate severity of injury. So you see in term, it can give us the parasagittal distribution, watershed distribution. However, in preterm, it can give the germinal matrix hemorrhage, which we will talk about. Okay, so moving with preterm neonate, they have certain factors for preemies. Some of it are extrinsic factors and some intrinsic factors, including mainly the poor autoregulatory capacity. So all these contribute to fluctuation in cerebral blood flow, and then eventually resulting in germinal matrix hemorrhage. So throughout the talk, we will split the pattern of injury into mild to moderate asphyxia versus severe asphyxia for all the age groups. So for mild to moderate in premature babies, it will result in intraventricular hemorrhage, and the majority of intraventricular hemorrhage occurs within the first 24 hours of life. Prevalence is inversely related to gestational age and birth weight. So what's the germinal matrix? It's a zone of cells along the wall of the lateral ventricles that's present during fetal life, which eventually will give rise to the neuron and the glia of the brain as they move to the periphery. And this germinal matrix will involute around 34 weeks of gestation. So that's why we don't expect to see the germinal matrix hemorrhage in a term babies. However, the last areas that contain the germinal matrix is what's called the ganglionic eminence, which is at the caudothalamic region. And that's where most hemorrhage will happen during preterm babies. So the grades for germinal matrix hemorrhage, including the using the Papile grading system, grade 1 is just at the caudothalamic region. Grade 2 is within the ventricle, but also but it's non-dilated ventricles. Grade 3 is the same, the hemorrhage with dilated ventricles, and then grade 4 it's the hemorrhage within the ventricles plus intraparenchymal hemorrhage secondary to venous infarction due to the medullary vein thrombosis. You can see here that's so ultrasound, coronal view, and then on each side bilateral sagittal views. I really like the coronal for assessing for early grade 1, grade 2 germinal matrix hemorrhage, as the idea that there is no choroid plexus passing the caudothalamic region, so then no choroid plexus, so no echogenic foci within the frontal horn. So if you see on the coronal some areas that looks echogenic within the frontal horn, it's suspicious, and you need to look carefully for the sagittal, where you can see here. So this is the caudothalamic region, and then this is the thalamus, this is the caudate. And it should be that the choroid plexus end around here. So this is more as like echogenic material extending anterior on the right side, and the same on the left side. So it's bilateral grade 2 germinal matrix hemorrhage. Same patient, 5 days later, the ventricles looks bigger than what it was, and then clearly we can see the hemorrhage, so it's more as a grade 3 hemorrhage. Other changes that can happen in preterm babies with the hemorrhage is the cerebellar hemorrhage, which was reported in autopsy by around 25% of preterm infant with very low birth weight. Usually we can detect the cerebellar hemorrhage either by the posterior fontanelle ultrasound or the mastoid view. And it's also believed that it's related to some residual germinal matrix along the foliation of the cerebellar hemispheres or along the roof of the fourth ventricle. So example of, again, this is coronal ultrasound, sagittal ultrasound. Echogenic area within the cerebellar hemisphere, and then on the sagittal, and then subsequently it's like evoluting to become more hypoechoic area. The other pattern of injury is the periventricular leukomalacia, or what's called white matter injury of prematurity. So it's related to the idea of low cerebral white matter vascularity in preterm babies, and part of the selective vulnerability for the cells of oligodendrocyte lineage within the white matter. Most likely will affect the white matter adjacent to the trigone of the lateral ventricles or adjacent to the foramen of Monro. As you can see here, some echogenic areas in periventricular distribution, which later on becomes more as like a cystic encephalomalacia on a follow-up 2 months later. So the white matter injury on MRI can look different. Early on, this injury by around 3 to 4 days, it can look as foci of T1 hyperintense. So hyperintense on MRI means bright, like something white on the MRI. But then later on, by around 6 to 7 days, these foci can look as T2 dark, hyperintense, or dark. So what we see on imaging is just based on the timing of the MRI, that sometimes we can see some overlap between some foci that looks T1 bright and foci that looks T2 dark. But basically, that's the timing. So for T1 bright, it's 3 to 4 days. And to see it on T2, it's around by the end of the first week. And the idea for that, the T1 bright foci, it doesn't mean exactly hemorrhage. It's more likely being astrogliosis or mineralization. So you can see here in this example, these are foci that's T1 bright, that's T1, as we see the CSF is dark. And some of these foci has T2 dark signal. So you see this one. However, this one, we don't see much of T2 dark signal. So maybe this is more earlier than the others. That's why still we don't see the T2 result. And in the stage of periventricular leukomalacia, we'll see more asgliosis, and that extending into the ventricular surface, some dysmorphic appearance of the ventricles, and then loss of white matter. So here I just want to highlight that it's important to differentiate between the white matter injury of prematurity compared to just normal white matter, but incompleted myelination. So with incomplete myelination, you still will have, so the top images are normal, and then the bottom one is white matter injury of prematurity. So here we see the ventricles looks normal in shape with a smooth contour, and then really it's when it's just an incomplete myelination, then there will be a myelinated layer between the ventricle and the white matter signal. As you see here, this is the normal myelinated layer separating the area that's bright, compared to when it's injury, you see it's extending all the way to the ventricular surface, and then just the ventricle looks bizarre in appearance. So that concludes the mild to moderate injury in preterm babies. Let's talk about the severe injury secondary to profound hypertension or cardiovascular arrest, and the outcome is usually poor. This will affect the central gray matter structures, and that's true for all the cases, whether it's preterm or term. It just there is different areas that will get involved, or more likely to be involved based on the gestational age. So preterm, it's more the thalami, anterior vermis, and dorsal brainstem. Basal ganglia involvement can happen, but it's less likely that compared to the term babies, can result in cavitation, shrink, or gliosis. Perirolandic cortex, again, less likely to happen. It can happen, but it's more with term babies. And then we can still see the germinal matrix hemorrhage and periventricular white matter injury. Imaging, so on ultrasound, we can see increased echogenicity within the thalami by around 48 to 72 hours, so like 2 to 3 days, or it can be just normal. And then on MRI, we can see the abnormality earlier, which I can make it just more shorter with this diagram. So on day one, usually you don't have much changes on T1, T2, but then it's the diffusion weighted images is we can see the early diffusion weighted changes. On day two, it will be more as like T2 hyper intense signal, so more hyper intensity within the thalami. And on day three, we can see the T1 hyper intense, which is the bright signal on T1. That's the time for peak in diffusion weighted images. And then on day 7, we'll see more as T2 dark signal and the beginning of pseudo-normalization of diffusion weighted images. So diffusions start to be back to normal, but then we can see more of T1 and T2 changes. And again, this is the same areas that's the thalami, anterior vermis, and dorsal brainstem. As an example here, diffusion weighted images and ADC. And so always when we say about something that's diffusion restricted, we need to have the diffusion weighted images and ADC map. So things that's dark on ADC and bright on diffusion, that means it's really diffusion restricted. So we see the changes within the thalami. Another example of patient who is 28 weaker, it gets scanned in the beginning with on day 5. So we can see it, and these are ADC values. Sometimes it's easier to see the diffusion restriction on ADC, which is the dark signal, easier than seeing the bright signal on diffusion weighted images. So we can see the dark signal on ADC within the pons, within the thalami, and along the optic radiation. Little bit of T1 hyperintense signal within the thalami, and some dark signal on T2 weighted images. And then we have the MR spectroscopy, which we see low NAA and increased lactate peak. We will talk about the MR spectroscopy later. And then the baby gets scanned 3 weeks later. Now we can see more of T2 hypointense signal and then the T1 bright signal. So to summarize the pattern of injury in preterm babies, we have the germinal matrix hemorrhage that's specific for preterm, white matter injury of prematurity, venous infarction as a part of grade 4 germinal matrix hemorrhage, cerebellar hemorrhage secondary to presence of some germinal matrix along the cerebellar folia and atrophy, and then involvement of deep gray matter structures in severe injury. So that will move us to the pattern of injury in term neonate. And again, for mild to moderate asphyxia, which is so moderate insult, if it is of short duration, then there will be little or no injury to the brain. However, when it's more prolonged duration, then that's when it will affect the intervascular zone or the watershed distribution between the ACA, MCA, MCA, PCA. So we'll have the parasagittal pattern of involvement. The brainstem, cerebellum, deep gray matter structures are usually spared just because in term, now there is the autoregulatory mechanism is working and it's more mature, so it's saving the patient from involving these highly metabolically active structures. On imaging, cranial ultrasound will have a limited value just because it's more a peripheral distribution, and we said that the cranial ultrasound can be limited for the cerebral convexities. So then MRI will be the modality of choice, which again, the diffusion weighted images, especially during the first day, showing the parasagittal distribution of restricted diffusion. T1 and T2, day 1 can be normal. Day 2, we will start to see the cortical swelling and loss of gray-white matter differentiation. And then later on, we'll see the volume loss. Example of what we are talking about. So T1, we don't see much of really, I mean, supposed to be, this is the parasagittal distribution, maybe a little bit here, not much really on T2 weighted. However, on diffusion weighted images, we see the restricted diffusion and the same on ADC. Another case, which we can see more here on T2 of edematous changes in a parasagittal distribution, residual diffusion restricted signal. You can see it better on ADC values, but here also some residual diffusion weighted signal. Another patient, which on the ultrasound, you see that doesn't really give us much of information. To say that there is like some changes, maybe just some limitation of like some effacement of the cell size as like a brain swelling, but doesn't give more specificity. And then even with having the resistive indices, it still look here within normal for this pattern of injury. However, on MRI, we can see restricted diffusion, as you can see it also on ADC values. And this patient on follow-up, we see the volume loss, the gliosis on FLAIR images, and vasodilatation of the ventricles. And we see how these gliotic changes extended all the way to the ventricular surface. Severe hypoxia for term babies, again, it's a central pattern. However, the areas of involvement are different, which is the basal ganglia is more likely to be involved, subputamen is more likely to be involved, and then perirolandic cortex is more likely to involve, in addition to the involvement of the thalami, the dorsal brainstem. Usually the rest of the cortex is spared. Imaging-wise, so on ultrasound, early on during the first week, we can see the diffuse brain swelling with increased echogenicity, CSF obliteration. After day 7, there will be more as increased echogenicity within the basal ganglia, thalami, and the brainstem, which indicate poor outcome. Or if we see by Doppler imaging that there is decrease in resistive indices. So the normal value for the resistive indices that we use is between 0.5 to 0.8. So below 0.5 or 0.6, this is like a low intracranial pressure and can be associated with poor clinical outcome. On MRI, basically the timing of change in signal, it's same between all pattern. Day 1, your to-go sequence is the diffusion weighted. Day 2 will start to have a little bit of T2 bright signal. Day 3, more of T1 bright signal with the peak of diffusion. And then day 7, the diffusion will start to pseudo-normalize, but then you will see more of the T2 bright signal in the areas that's involved. So the teaching point is that conventional T1 and T2 are most helpful by the end of the first week when the diffusion weighted images will start to pseudo-normalize. Example of the area of involvement. So we see some T1 bright signal within the lentiform nuclei, ventrolateral thalami on T1 weighted images. On T2, some dark signal here, and then on diffusion, it's a little bit of remaining signal. However, again, we see it much better on ADC to see the restricted diffusion. Another patient, we see more of the T1 bright signal in basal ganglia and thalami, and then perirolandic cortex. And then on 7 months follow-up, we see the volume loss with gliotic changes, cystic changes, and then again, within the perirolandic cortex. Another case that we see on T1 weighted images doesn't look that it gives us much of information, little bit of signal within the cortex. Is it really true? Is it just an artifact? But then when we get the diffusion weighted images, it's so diffused to the point that you would think, oh, maybe this is normal. But when you look on the ADC, this is too dark for being normal. And then there are some areas in between that looks spare. So, and at this point, which we will talk about later, just having the ADC values that sometimes we can use, it's very helpful to say, oh, this is all abnormal. So it's a diffuse hypoxic ischemic injury involving not only the basal ganglia region, but also the cortex is involved. Okay, so that concludes the pattern in term. And now we will be moving to infant and young children. So usually the mechanism or the cause for their hypoxic ischemic event is different from those in a preemie or term. It's more likely as a drowning, choking, or non-accidental trauma. The pattern of injury is different from neonate, and that's related to more of brain maturation and the near completion of myelination by around 2 years of age. And some pattern of injury that can look similar to adult will start to appear depending on the age of the kiddo. In mild to moderate, will still give us the white matter, the watershed zones of distribution with some sparing of periventricular white matter. So you see the pattern here on the CT as these hyper densities with loss of gray white matter differentiation. and then we see the restricted diffusion on MR. In severe, it can be different during the infant life from 1 month to 1 year compared to 1 year and older. Again, based on the maturation and of the brain. So features between both birth asphyxia and later infantile asphyxia will appear. The basal ganglia is still the area of involvement, the thalami, and some cortical injury. However, in older kids, usually they're relative sparing for the thalami and perirolandid cortex. But then, yes, basal ganglia is still involved, and we will get more as cerebral cortical involvement in anterior frontal or parieto-occipital cortex. So in terms of imaging, cranial ultrasound is not going to be helpful at this point because fontanelles are closed. So the other modality that we can use in those kids is the CT. Early on, it can be negative, or we can see just a subtle hypodensity. Subsequently, there will be more as diffuse gray matter abnormality and cerebral swelling. Hemorrhagic changes, we can see it around 4 to 6 days, and then later on we see the volume loss. On CT, I want to highlight 2 signs that it basically means poor outcome when we see it. So one of them is the reversal sign, which is reversal of normal attenuation of gray-white matter. That can happen within the first 24 hours of injury, and it's proposed to be related to distension of deep medullary vein secondary to venous outflow obstruction from elevated intracranial pressure, which I will show you a picture about. The other one is a white cerebellar sign, which is just the cerebellum remain with a high attenuation compared to the rest of the cerebral hemisphere, secondary to diffuse brain swelling within the cerebral hemispheres. And it's suggested that it's related to redistribution of blood to the posterior circulation. Both these are poor neurologic outcome. So that's a normal brain in 4 months old. So you see, basically, this is the white matter area. So white matter is the dark compared to the cortex. But then this is a case of reversal sign in 4 months old from the injury. So you see that's the reversal between the gray-white matter or cortical white matter. So the cortex looks darker than the white matter. And it's basically a bad sign. And this patient is NAT. That's why we see some areas of hemorrhage too. And this is the white cerebellar sign, where we see all the cerebral hemispheres looks hypodense because of edema, and then the cerebellum looks white in reverse. On MRI, still diffusion weighted images is the modality of choice for the first 12 to 24 hours, and shows the area of distribution. And then later on, we can see the changes within the basal ganglia and the cortex, and T1 and T2 can be normal up to 2 days of age. That's another case we see on the CT, diffuse brain swelling, and then as a result of this, the white cerebellar sign. And then on diffusion weighted images, we see the restricted diffusion within the basal ganglia and more of restricted diffusion within the parieto-occipital cortex. The same changes that we see on T2 weighted images, so more as brain swelling and edema or T2 bright signal within the involved areas. Another 2-month-old with cardiac arrest secondary to NAT. So we see the complete effacement of cortical sulci. There's really nothing throughout the brain, and very slit-like ventricles, some areas of hemorrhage, subarachnoid, subdural hemorrhage, and the patient didn't make it. He passed away in a couple of days. So this is the only images that we have. So that concludes the pattern of injury in neonate and in infant and young children. I will talk about the advanced imaging modality that can help us in early diagnosis, which is MR spectroscopy, ADC, and ASL. So MR spectroscopy is most helpful in the first 24 hours following the insult. It's basically help in detection of lactate elevation at 1.3 ppm within the areas that injured. So whether it's the deep gray nuclei, the cortex, or the white matter in parasagittal distribution as early as 2 to 8 hours. And then even we can see glutamate peak around 2.3 ppm, which is related to release of these excitatory neurotransmitters that happen during the time of injury. So that's an example. And then, as you know, for MR spectroscopy, so it has different, we call it TE time. So it's either the short echo time, long echo time, or intermediate. So here within the pictures that I give you, it's short echo time and then long or intermediate echo time based on the millisecond for the scan. So we can see in short echo, we can see that the lactate elevation and then the GLX, which is the glutamate peak at 2 ppm. These are the ppm times. And then for the long echo, we see low NAA and then the lactate peak too. So the pitfalls with MR spectroscopy, it's limited with preterm babies just because they usually have higher lactate peak, like that's normally higher lactate peak and lower NAA compared to term. And then the lactate peak, like the term babies can normally still have some lactate elevation despite being a healthy term babies. So it has its own challenges, but with all the clinical picture of injury and some other findings, it can be helpful in confirming the diagnosis. The second modality is the ADC value. So this is one of the articles that talks about changes in brain water diffusion during the first year of life. They took 4 areas of white matter and then 4 areas of gray matter. And we can see here within the plot or the bar graph. So what they, before that, so the dark, or the black one, it's the first is 1 month, during 1 month, and then the white one, it's at the end of the first year. And then they saw that the ADC decreased with age in all regions. And ADC is significantly higher within the white matter than the gray matter in all the areas. So it's always higher within the first month compared to the rest, and then it's higher within the white matter compared to the gray matter. And then they give the graph for these that we can plot the numbers and see based on the age. So results suggested that neonate and infant, the water diffusion is highly dependent on both the subject age and the brain location. Reduction in average diffusivity or the ADC value by more than 25 to 35% is associated with poor long-term outcome. And the average diffusivity values that's lower than 800 within the thalami or posterior limb and lower than 1100 within the white matter between 1 to 4 days of age is associated with permanent injury. And this is another reference that talk about these details. The other modality is the ASL perfusion, which the ASL perfusion, it's gaining more popularity in pediatric population just because you don't need to give contrast to get them perfusion images. So it's helpful in peds. It's just basically a sequence that can give you some more information. And with perfusion, usually what it's going to show is increased perfusion within the injured areas. That is initially when the insult will happen, there will be some decrease in perfusion, but then secondary to regulatory mechanisms, there will be increased perfusion, and that's what we can detect. Timing of this evolution can change a little bit with the treatment of hypothermia, which we can talk about. So that's an example of patient who gets scanned at 24-hour of age. I mean, we don't see much changes on T1 and T2. This is the ASL. So ASL, this is like the raw data of the ASL or the black and white. Still just needs post-processing. You can get the colored map. But we can see that there is some increased perfusion within the basal ganglia region. And on MR spectroscopy, we see elevated lactate with low NAA. And then on ADC, there is restricted diffusion within the lateral thalamoid. With that tells that there is, with putting these three together, that there is some injury happened despite the normal T1 and T2. And then the same patient gets scanned 4 days later. Now we can see a little bit of T1 bright, T2 dark. Still the ASL give us the increased perfusion, more of lactate elevation, and then much more extensive restricted diffusion. So last part of my talk, briefly about the therapeutic hypothermia, just the changes that we can get on imaging when with the cooling. So what's cooling for? I'm not that familiar with how the mechanism. I guess the neurologists and pediatric people, they know how exactly the mechanism. But for basic understanding for radiology aspect, they basically place the baby in a cooling cap or blanket and then lower the temperature to 33.5 degrees Celsius. And they keep the baby in this low temperature for 72 hours, and then they start rewarming the baby after that. This is supposed to result in decrease or prevent the spread and severity of brain damage. It doesn't really, it's improved the long-term neurological outcome, which we can see. So the use of therapeutic hypothermia shows significant reduction in neurodevelopmental disability in early and 18 months follow-up for children who are treated for mild to moderate hypothermia. And likely the idea is that the therapeutic hypothermia ameliorate or change the secondary energy failure, but the mechanism is unknown. And it's better result for mild to moderate injury compared to severe. However, still there is some exceptions to this. So that's an example of patient that was scanned on day 2. So some of the changes on T2, some of the edema, but then it's more extensive ADC changes on the diffusion. And then they scanned after the hypothermia and see most of these changes resolved with only residual restricted diffusion within the parieto-occipital region. So the effect on imaging is that evolution of these diffusivity changes is prolonged. So we said that the diffusion starts to pseudo-normalize around 6 to 7 days. But after therapeutic hypothermia, this normalization can take up to 11 days. Other things that we should be looking for possibility to happen, which is 10%, they can get some small intraventricular hemorrhage in those who are treated with hypothermia, but there is no non-clinical consequences for this hemorrhage. And then the presence of elevated lactate or significant reduction in diffusivity during hypothermia suggests severe injury has already occurred and is not responsive to the therapy. So that concludes my presentation with saying observed injury pattern are highly variable and depend on brain maturity, severity and length of the insult, type and timing of imaging. Making the diagnosis for using ultrasound, CT, MR require a clear understanding of various imaging pattern of injury. Diffusion-weighted ASL and MR spectroscopy are most sensitive imaging modalities in the early hour following injury, but then delayed imaging in the subacute phase may be helpful in determining the overall extent of injury and long-term prognosis. These are references, and the give some time for the CME questions. So, and then the answers is MRI is the most sensitive modality, especially with diffusion-weighted ASL and MR spectroscopy. And then for the factors or the effect, the pattern of injury is all the above. Thank you so much. Happy to take any question.
Thank you, Dr. Mahdi, for the excellent talk. I have a question about the timing of MRI in the post-cooling phase. Typically, we do the MRI after the cooling is done, after 72 hours, when the diffusion changes are maximum and T1 changes have started to appear. But as you said, that the pseudo-normalization in diffusion-weighted imaging can take longer, even after like 10 to 11 days. So do you suggest that we should do the MRI after the first week when both T1 and T2 changes are at its maximum and we also see the diffusion-weighted changes?
So I think it's just, it's a great question. You know, I think it's more as for us to be aware that if we still see the changes, then it could be related to pseudo-normalization. Doesn't exactly mean it's the injury is still there. I mean, we do the same thing in our institution. We get scanning post therapy, post cooling around 4 to 5 days. So I don't think that you should change it. I mean, if we wait till the end of more than the end of the first week, we might not see anything, and that also can give us a false negative.
My another question is, do you see normalization of MRS because of normalization of the lactate level on the second day of life? Is that your practice? Or like usually the lactate level becomes normal in the latent phase between 24 to 48 hours. So MRS can give false negative result. Is that true?
I'm not aware of this. On the other hand, for example, like if we scan the baby on day 1, we see some elevated lactate, but if we wait longer and scan on 4 days, we can see even a higher lactate peak.
Thank you.
You're welcome.
Sorry, I have one more question if nobody else has. So after a few weeks of hypoxic ischemic injury, sometimes we see the delayed post-hypoxic leukoencephalopathy. What is the mechanism of that? Is that because of secondary deficiency of aryl sulfatase A, or it is something else?
It's a good question. I will need to look further into this. I can follow up with you later.
Yeah, sure. Sorry. Thank you.
You're welcome.
I did have one question. So I know like prognosis is always a question that parents have when we get these imaging that shows something on the brain. It's something that's very stressful for the parents. For IVH, we have good prognostics based on the grading of that. But for more of these watershed injuries, you know, I know obviously if it involves the putamen or the basal ganglia, that's going to be worse. But for more of the watershed injuries, is there any good tips for prognosis on those?
I mean, it depends, right, on the area that's going to be involved. If it's frontal versus being more parietal, is there any involvement of them along the motor tract? I mean, I don't have like a clear prognostic point other than just based on the area. It's case by case basis.
Thank you.
Yeah, thank you so much for your time today, Dr. Mahdi. We really appreciate it.
Thank you.
Have a good day.